All right. Well, I'm going to go through what I often spend an hour and a half or at least an hour talking with others about. I'll try to do that in, take off a minute or two from that. Jamie wanted me to talk for 3 hours, but so I'll try to do it in 10 or 15 minutes. And so some of the slides are just going to be examples of this. But for a moment, I'm going to start with, there we go. I'm going to start with why is this an issue? What is it about suicide and death by suicide that is so hard for us to all talk about? And a lot of that is that we are judgmental animals. We often forget that. That's probably part of our survival over thousands of years. And so anything that we judge, anything that we fear, anything we don't understand, we tend to judge it harshly. And my premise as a psychiatrist is that we don't even know what life is. In fact, if I asked you each to write an essay today on what is life, we would take up way more than the hour. And on the other hand, if we don't understand life, how do we understand death? So it's really hard for us to get, whatever your faith and background is, it doesn't matter. At some level, we still fear that. And it's actually thought in some of the psychodynamic literature that one of the reasons people go into healthcare, and particularly in the field of medicine, is it's a high-level defense mechanism of coping with the fear of death is to do a job where you fight death every day. And so I would argue that trying to prevent suicide would be a great way to honor that concept. So another problem with judging things is we tend to use negative language. So for most of my career, we said committed suicide. And of course, that sounds like committing a crime, committing a sin, very negative language. And then we tried for a little while under this Zero Suicide in Healthcare initiative to use completed suicide. That also did not go over well because people don't complete cancer. They die from cancer or die by cancer. So we're trying to change our professional language, which we hope eventually will change layperson's language to died by suicide or a suicide death. Suicide attempt makes sense, but we do not want to say a failed attempt because it's, again, puts a negative connotation on that. So we would stick with a suicide attempt as a way to get somewhat past this. The other piece that has happened, and this has really all been since 2010, so it's a pretty new initiative in the scheme of healthcare, is that there were a group of people called suicidologists, literally in the ivory tower, doing a lot of research on deaths by suicide, but they really weren't sharing it with clinicians. And finally, we're getting to do that. We've got some very good ones, in particular, Dr. David Jobs, who I'll mention later, who's created one of the treatments for suicidality. And they found that, again, people don't know what death is. People are not trying to die, but they are trying to end their pain, physical pain, spiritual pain, emotional pain, what have you. They're not really trying to die. And so our concept here is to try to help people instill hope and instill reasons to help them get past that pain, whatever that pain might be, and work on that. So the United States, while the rest of the world, according to stats from the World Health Organization, is declining in the rate of deaths by suicide, the United States is still and currently on the upward trend. We are going in the wrong direction. So I purposely used these two dates, 1990 and 2013, just to demonstrate that. So we were at 12.5 per 100,000 individuals in the U.S. in terms of deaths by suicide in 1990. And in 2004, we saw it drop. And although 11.1 doesn't seem like a difference, it's a lot of people when you multiply that by 364 million or whatever our country is. Then in 2013, we went back up to 12.6, and now actually we're at about 13 per 100,000. I kept the 12.6 because it matches the 12.5 in 1990. The problem with this is we don't know what we did right to drop it to 11.1, and we don't know what we're doing wrong, as it were, or not doing that we used to do that's allowing the rate to go up. So that's a problem here, and of course it's higher represented in mental illness, but there are recent studies showing that not all deaths by suicide seem to involve mental illness. There are other factors at play. I'll just show this for a moment. This is kind of the scare slide, just to give you that even though it, 13 per 100,000 seems like a low base rate, it's still way too many people. And there are certain groups that have a higher representation of death by suicide. And one of those happened to be within healthcare, particularly physicians, particularly dentists, and more recently studies have shown that veterinarians have a very high rate of death by suicide. And then law enforcement is very high on the list, where the rate of law enforcement, men and women being killed in the line of duty is much lower than the rate of their death by suicide. So as bad as those events are when we have an officer shot and killed, their death by suicide rate is actually higher than that. So this is a real problem. This is something we could really do more about. And this is the most recent meta-analysis I could find. It just points out a few of the risk factors, just so we have that piece in here for evidence base. And of course, it always shows everything you do in healthcare, and particularly in mental health care. Prior behavior is the single best predictor of future behavior, no matter what it is. So if somebody has attempted suicide in the past, there's a much higher likelihood they will attempt in the future. Men definitely have a higher rate of death by suicide, about 4 to 1 with women. And most of the reason for that is that men tend to choose guns, women tend to choose pills, which are less effective, and that's a good thing in this case. But that's an issue. This gives you just real quickly a little bit of real data. I was showing you a few years, and I'm purposely stopping with 2014. I'll explain that in a moment. In Summit County, where my main job is, and you can see the range, right? The whole age range is represented. Of course, the sort of main adult years are higher represented here, but you do see some individuals in the 90 to 99 range, and even one in 2012 who was over 100 years old, dying by suicide. If we break that down to male and female, and this is real data, real people, you'll see that 4 to 1 ratio of male to female just in our own data set within a given year. We average about 75 deaths by suicide per year. I took the data, looked all the way back to 1983 in Summit County. That would have been a slide you couldn't have read, so I went with a few years here. The reason I stopped at 2014 is that in 2015, the entire country, and Summit County was part of that, went way up. So our number of 76 in 2014 went to 110 deaths by suicide in 2015, and we do not know why. We do know who was most represented, and that was Dr. Boltry and I, basically. It was middle-aged white men were one of the biggest reasons for it, nationwide, and then second to that, middle-aged men of all races. So that's a huge issue, and of course, we've had other blossoms of certain types of deaths by suicide, like in Stark County. They've had some more deaths in the younger population and school-age individuals, and there seems to be some relationship to media, including the TV series 13 Reasons Why, which, much to my chagrin, is about to put out its 3rd season. So it's kept going, even though it does seem to be associated with some increases. Like the opiate epidemic, we tend to talk about deaths. So suicide, we talk about deaths, but like the opiate epidemic, we're actually trying to deal with the bottom of the pyramid, people that are using opiates inappropriately or recreationally is who we want to target for prevention. In the case of suicide, we would like to target those who are thinking about dying by suicide. And American healthcare in particular has not done that well. So that's what we're talking about today. Again, we had the suicide prevention field of these people in the ivory tower not really sharing with healthcare, which put a burden on emergency departments and paramedics and so forth. We're looking to do this. We want the appropriate overlap. We don't need full overlap. We need the right overlap to take their information and then be able to make suicide prevention a core focus in healthcare of all types, whether it's the newer version of accountable care organizations or standard healthcare settings, private offices, and the like. So our system, our country is built on checks and balances. I would say that right now our healthcare doesn't have those checks and balances. So all the cheese slices, if you will, are arranged in the same way, which means somebody can fall through the holes. And I'll just do this all at once to make it simpler. But basically, you have the person who's thinking about dying by suicide, again, really thinking about ending his or her pain. And we aren't asking, and therefore they don't tell us. We aren't doing much to help their safety because we don't even know what to do and so forth. And of course, we end up with injury or death. We want to rearrange those cheese slices so that we have checks and balances at each point. We want to screen, and I'm going to tell you concretely at the end a few examples, screen for suicidality. We have very good evidence-based screens for this. Once you get that, you may already have helped avoid that. We want to assess more detailed at that point and then create a collaborative safety plan. This is not the same thing as a safety contract where you say to your patient, please sign here, you won't kill yourself before you see me 3 months from now, which is about how often people see their psychiatrist. Those have zero evidence base and not good for my forensic work. They're useless if I'm trying to defend a physician whose patient died by suicide. If all they had was a so-called suicide contract, they're going to lose that case likely. So please don't choose that as your choice. The big thing that's come out of zero suicide in healthcare, one of them at least, is that we now know that we can treat suicidality as its own entity. It doesn't matter that we treat the depression, the schizophrenia, what have you. What's important on top of that, separate from that, in fact, is to treat suicidality, and we do have some evidence-based approaches, which I'll touch on a little bit in a few moments. And then we know that follow-up makes a big difference, and I'll give you an example here. We looked at the evidence base for the 7 components, and I won't go into detail all 7 of those today for time's sake, the 7 components of zero suicide in healthcare. And the one with the best evidence base is the contact after somebody has gone to a crisis center or called the crisis line or used it to the crisis text line or is leaving a hospital and going back to the community, any kind of transition. They've done studies on snail mail, email, texting, phone calls, and postcards as another version of snail mail, although those have to have very little information on them because of HIPAA, because the postal carrier can see them. They've done those studies. It can decrease the rate. If you send those about 2 days or make that contact about 2 days after somebody leaves your transition, your setting, or has called the crisis line, it actually decreases the attempt rate or the reattempt rate of suicide by 50%. And it's almost free. So we're doing a lot of this in Summit County. We have a number of agencies working on, and actually some are really doing this robustly at this point, such as Portage Path. I just actually met with them this morning, and that was brought up a little bit. And the reason we're calling this zero suicide in healthcare is because when you look at studies of where have these people been in the weeks or months before their death by suicide, they've been in our offices. They have come to see a counselor, a psychiatrist, a family medicine physician, an OBGYN often, if for healthy women, often is their primary care doctor. They've been to the emergency department. And guess what? We didn't screen them. And my belief is it's because it's human nature. So I am a family medicine physician, and Dr. Boltry can correct me, but I presume I probably have to see at least 4 patients an hour to keep the doors open, the lights on, pay the staff, so forth. And maybe it's 5, right? So I've got 15 minutes per person. And so I've got Mr. Jones. He's coming in for me to work with him on his cholesterol. We got his labs back. It's not going well. We're going to talk about medications. And even if I'm a prudent family physician and I happen to decide I'm going to ask questions about suicidality, if I get a yes, that's not going to be a 15-minute appointment in our current medical system. So guess what I don't do? I don't ask. That's just human nature. I'm not blaming anybody. That's true across the board in American healthcare. What we're suggesting with zero suicide in healthcare is a system approach so that I can get a yes and I know what to do. And the ideal in integrated care is I would say, Mr. Jones, I'm really sorry to hear that. I'm going to help you with that. Let's finish your cholesterol discussion. And I'm going to walk you down the hall to Mr. So-and-so, Mrs. So-and-so, Dr. So-and-so, and they're going to help you because they're experts in this.
You don't want the plan to be, you're suicidal, let's call the police.
Right. You don't want, unless it's that urgent, and you don't want it to be,
You don't want that.
Here's a list of 4 psychiatrists, call and find an appointment, which will be next year or something, right? So none of that's a good process, but that has been our system. And so our goal with zero suicide in healthcare is to make sure that people are being screened in all settings. And I'll give you my other piece to this. So I still remember, actually, probably as a college student, going in, as we're all patients, we go in, they give you the clipboard, and they wanted me to write down healthcare information that I knew about my grandparents. Well, I can tell you they didn't talk about their healthcare very much. Wasn't common, and I'm not that old. They were. They didn't talk about that. Yet they didn't ask me anything about my own mental health state. That's a stigma. And so the idea behind screening is partly to capture people now. It's also, although it will take a generation, if right now we're screening, as the United States Prevention Task Force has recommended, we're screening everybody age 11 on up in pediatrics offices for suicidality and depression, and particularly depression, but to catch the suicidality. They will grow up and it won't be a stigma when their kids are in there asking the question. We need to change that monologue. It can't, or dialogue. It can't be, we ask about your grandparents' health conditions and not ask you how you're feeling. So that's just a quick version of why it's in healthcare. We're not saying we're going to save everybody, but at least the people who touch our systems. There are several concrete ways to do this. And again, for time's sake, I'm going to go fast. There's a readiness survey that organizations can actually take, which will let them look at a bunch of facets of how they're doing with the zero suicide approach. There's also a workforce survey. I'll give you an example of that, which lets the staff tell you anonymously how they think they've been trained. And here's an example of one that looked at people in a lot of states, and I'll cut to the quick. You will see here that not even half thought they had either the skills or the training or the supports to deal with somebody who might be suicidal. And my premise, therefore, is they don't ask. Because if you don't know what to do about something, you're not going to ask. And the old adage in medicine is you don't find what you're not looking for, right? We've all been trained that way, and on probably all of our various fields here. So, and so this is really true. The Substance Abuse Mental Health Services Administration, if you've not seen that SAMHSA acronym before, that over the decades, individual mental health clinicians have made heroic efforts to save lives, but systems of care have done very little. So it's about systematic, and you'll be able to get the slide set, so I'm not going to do all these bullet points. But it's about systematic framework, and it's also about approaching suicidality as a medical comorbidity and as its own entity. Those are two big takeaways today that I hope, if you remember nothing else, you remember those. The other nice thing is that zero suicide is not a pie-in-the-sky dream. It's actually been achieved. The Air Force has done a lot of good work on this. For time's sake, I'm only going to do one today, which is Henry Ford, which is the large system in Michigan, not as large as Beaumont, who's apparently soon to take over SUMA. But you'll notice, and this is the same scale I gave you, out of 100,000 participants in their HMO plan, they were at 110. Not 13, not 11.1, 110 deaths per 100,000 members. Horrific. Thankfully, somebody noticed it. So they created a plan they called Perfect Depression Care, and they launched it. And the nice news is that in 2009, they actually hit zero. And I believe I read in 2014, although the graph doesn't go, they also hit zero. So it actually is achievable. That's phenomenal. And I'm going to show you an example. This is the fancy slide, which you can peruse at your leisure. But the point is that we need to change our core values, our beliefs, our attitudes about this. We have to use the evidence base, which is actually very robust at this point in many facets of this prevention, screening, prevention, as well as treatment. And then we have to change into a systems mode in order to save lives. I want to mention at the very bottom there, in particular, the websites. So ZeroSuicide has now .org and .com. They actually are different, but there's a lot of great information on both, and they are free. Screening tools, assessment tools, evidence-based for all 7 facets, leadership being number 1, and then so forth for the Zero Suicide Initiative. Just quickly then some examples. So here's the National Suicide Prevention Lifeline. If someone were to call the number, it actually then triggers to your local call center. So for in Akron, it's actually at Portage Path at Psychiatric Emergency Services. And the reason for the local trigger is that they know the resources. There's no way the national number is going to know that. So they know how to help you. They also know how to get 911 to your house if need be. But you'll notice how detailed this is. By the time you've kept somebody on the phone and if you've gotten this much information, you've already engaged them really well. You've got a really high chance of helping them with suicidality. You could have, of course, ascertained you need to send 911, et cetera. I'm going to focus on the far right-hand side. They're the buffers and connectedness. So I mentioned that we are social animals, and because of that, we need to connect. We need social connectedness. That is a huge preventer for death by suicide. And many studies show that people who die by suicide ultimately were isolating and withdrawn even from their family, even within their own homes. They just weren't coming out of their rooms. Here's one example, the Columbia. They call it the CSSRS, the Columbia Suicide Severity Rating Scale. just as an example, this is the most evidence-based of all the screeners. It's embedded in Epic. It's embedded in other kind of electronic records, so it's easy to use because there it is. I like this version here because it normalizes the thoughts that people have. So for example, A, it is a fact that nearly everyone has at some time felt hopeless. That normalizes it. Now it's easier to ask the question now, hey, have you felt hopeless? If you've just told them lots of people at some point feel hopeless, they're more likely to give you an honest answer. Just like B, it's also a fact that many people have had thoughts of ending their lives. Again, you're normal, and it is true. Many people have had that thought somewhere along the line, just like women in particular, though it obviously happens with fathers as well. Mothers do have negative thoughts about their crying infant after the third night of no sleep, and women don't want to ever admit that. And yet, if we could admit that, we could work on that. That's a stigma. Same kind of idea. Let's normalize it. Then, of course, drugs and alcohol have to come into play for this. This is the Henry Ford one because they did such a good job. I wanted to show it to you. They created this de novo. Nobody else was doing this. So you'll see they got into alcohol, they got into drugs, and then they got into the depressive type symptoms. Here's an example of the patient health questionnaire 9 that can be used and embedded right in the electronic record. This is a screener. Many pediatricians' offices are using this because of that preventive task force motive. If for some reason they think 9 questions is too much, there's a 2-question version. The 9 is what I've seen in practice in a few pediatrics offices that I've visited, and that seems to work really well, and it gets a good discussion going. This shows suicidal ideation as its own treatment plan item. It's not embedded under depression or something. Again, just an example. There's a nice article on the caring contacts, that is the follow-up visits, just to give you a sense of that if you need a reference. This is an example of a safety plan. This is, again, not a contract. This is sitting down with a person. This takes time. It's often not a physician. It's often a social worker, a counselor, or a psychologist who's going to be doing the ongoing therapy, and they're going to sit down and engage the person around thoughts and feelings and good distractions and coping strategies and so forth. And then, of course, the final step, which gets controversial in our world, is making the environment safe, because that may include putting a trigger lock on your gun, putting it in a safe, or maybe even giving it to your brother-in-law for safekeeping during that window that you're not feeling quite so safe. So we really emphasize we're not trying to take people's guns away, but I think it gets turned into that. Here are some examples of some of the treatment models. Cognitive behavioral therapy is phenomenal for this. There's actually a CBT for suicidality. In fact, we brought the Beck Institute to Akron and trained a lot of people across our agencies on that. DBT, dialectical behavior therapy, created by Dr. Marshall Linehan, specifically to treat individuals with borderline personality disorder, but it works on the self-harm components. It takes a lot of training to do that, as it does to become a true CBT diplomat. DBT involves both group and individual approaches. And then CAMS, Dr. David Jobs, again, one of the suicidologists, created it. It's a wonderful tool. It's a flipped classroom approach. It's done at cost. Maybe it's less than $200 to do it online at your own pace. Then he or his members of his team can come in and help you learn how to implement it. He tried the other way around. It didn't work very well, so this works much better. Other versions that we use in the community, some of them tied to the lay public, like Question, Persuade, Refer, to help get rid of the stigma. That's like an hour and a half, more like a CPR class.
We started teaching that to our medical students in the first year, I think.
That's awesome.
Where they put it.
Okay, so that you didn't have it yet in your class, but they've added it.
I think they added it after,
awesome.
Yeah.
So it's another really good approach. AMSR, I actually went to one of their trainings as well, just to see what it was. It's a day and a half. So, you can titrate this to your audience and where. So you want to get a bunch of people trained. QPR, it's perfect. Let's get this out. Let's get rid of stigma and so forth. And then this just gives you a little bit more about building your plan. For time's sake, I'll stop there.